So this is my opportunity to get to introduce the first presenter. But before I do, we have to stay compliant with all rules, regulations, and expectations, which means that the very first thing we have to do is put up the official CME disclosure form and say that this person, I believe, if I'm correct, yes, okay, good, maybe nothing to disclose. That's great. Which is, at least officially, but I believe our first presenter is going to share a lot of great information. So I'd like to ask you to put your virtual hands together for a person who is board certified in physical medicine and rehabilitation and he did his fellowship in pain medicine. He told me yesterday that he really loves rural Oregon and has worked there for quite a long time and he is particularly attuned to some of the real challenges that have happened in rural Oregon over the last decades as industry has left and how that has really translated into some of the things we're going to be talking about today around opioid use and deaths of despair. He is an undergraduate from the University of California, Davis, where he graduated with honors in biochemistry. He did his medical training at the University of Chicago and his internship at Northwestern, where he was awarded Intern of the Year. He performed his residency at the University of Washington, where he was honored with the Harborview House Staff Award, and did a further fellowship at Kaiser in Oakland, California, and was awarded the Fisher Peabody Award for Excellence. We got to say these things because it's exciting to have great presenters. He is currently the medical director at Salem Health Pain Clinic, where he received the Best Care Award in 2019. Would you please welcome the one and only Dr. Paul Coelho. Dr. Coelho, welcome. We're so glad you're here.
Good morning. Thank you. David Ferris and I have a slide deck that we are sharing. And David Ferris, you're on. So if we could maybe let David start. I think the beginning of the slide deck is David's. And for those of you that don't know David, he's the director of the Oregon Medical Board. David, I hand the gavel to you.
Thank you. And I'm happy to be here to talk to you all. I don't like talking to computers as much as I like talking to a live audience because I sort of like to see how people are responding, whether they're asleep or awake. I am the director of the medical board. I am the medical director, which is a bit of an odd title. I'm staff for the medical board. I'm not on the board. I don't vote. I work for them. I put things on the tee and let them make decisions. I've been there now for a little over 2 years. My background is I was a pediatric cardiac anesthesiologist at Randall Children's Hospital for 33 years, retired for all of 30 days, and then started this job. The reason I am speaking today is to try to give a little insight into problems that prescribers of opioids face in terms of discipline issues before the Oregon Medical Board. I'm going first because I have to jump off shortly I'm supposed to be in another meeting at the same time. Sometimes that happens. I'm going to tell you that working in law enforcement is quite a bit different from doing OR anesthesia, but it is always fascinating. If you could put up my first slide, please. The board actions are complaint driven. We cannot, don't want to go out and looking for trouble. For instance, the PDMP, we are forbidden by statute from going and looking for problem prescribers there. We certainly use it every day when we get a complaint, but we are complaint driven. So my first slide is actually a screenshot of a real complaint from a pharmacist. If we can jump to that, it was slide 44. That might be where we need to be if they didn't get rearranged. Yeah, it was right after that one. Next one. So the process, when we get that slide up, the process goes, we get complaints from all sorts of sources. Most commonly, I think, patients and family members, but in prescribing cases, they probably more often come from pharmacists or other prescribers who picked up a patient later on. That's the slide is supposed to show that. When we get that, we look at it to see if we think there's any validity to it. Often in prescribing complaints, it's not a question. We have to look at it. The We look at the PDMP to see if there are other patients we should be looking at. We look at the index patient. We get medical records. We have a line investigator. Most of them are former detectives, and they will accumulate all the information, do interviews, and present the data. We then send it, I look it over, we send it to a consultant in the field. We rely on expert opinions to tell us what is negligent and what is not, what is the standard of care in the field. I don't know. Most of the board members have more knowledge about it than opioid prescribing than I do or did. I'm learning a lot about it, particularly from Paul and other consultants that we use. So then the board determines if there was negligence or not and acts appropriately. Slides would really help here because I was going to speak from my slides. If there is a single act of negligence, there's often not a lot to do about it. If there is a pattern of negligence, or in some instances gross negligence, which is willful disregard of the patient well-being, then there is something to do about it. And that can take the form of a corrective action agreement, which is considered non-disciplinary. It is often a course of required education and intermediate steps, sometimes a mentorship in the field that we're interested in prescribing. It is often chart reviews, help with problematic patients. It can take the form of a stipulated order, an SO, which is disciplinary. Both the CAA and SOs are reported to the National Practitioner Data Bank, the one being disciplinary, the other not. The SO is the disciplinary version, and it will give limitations and set guardrails on practices. Until a couple of years ago, those were relatively strict and simple. You could refer the patient out to a pain specialist or other prescriber, or taper the patient down to less than 90 MED, get them off their benzodiazepines, start doing monitoring. Since that time, there's been more of a shift toward harm reduction as the model, recognizing that not all patients can or will be tapered, but they should be moved in the direction of doing as little harm as possible, getting them down as low as possible, hopefully transitioning to buprenorphine therapy. In many instances, we have found consultants who looked at extraordinary cases where the MEDs remained high and did not find negligence in the prescribing for that particular patient, but did find negligence in the lack of monitoring. The UDSs were scant if they existed at all. MRNs and contracts were scant if they existed at all. They, I can't see the slides either. Patients on methadone need a yearly EKG. There are certain standards that have become accepted as minimum by our consultants. And that is the basis now for the document that you can find on the OMB website, which is the Statement of Philosophy. There are a lot of areas in which the board cannot possibly delineate what the minimum expectations are, what is negligent and what is not. Pain prescribing is something of an exception to that, in that the expectations are pretty well delineated. And that allowed us to create this Statement of Philosophy, which is probably the most prescriptive one on the list. If you go to the website under topics of interest, I think it is, you can click to Statements of Philosophy, and there's a list of 20 or so. For instance, the board will look at a particular issue like, say hormone prescribing, and say, this is how we look at it. These are general guidelines. We can't tell you exactly what the cutoff is, where we might find negligence and where we won't. But in pain prescribing, it's a little more, it can be a little more prescriptive because there are recognized standards. And that is the best way that I can tell prescribers to stay out of trouble. In my first 12 months in this job, we opened 19 fresh investigations on prescribing complaints. Most of them were serious allegations. I can't tell you how they all were adjudicated in terms of an SO or CAA or closed with no official action, but they were serious complaints. Most of the problematic patients are legacy patients. We get that. Pain was the fifth vital sign for too long a time, as it turns out. We thought we were doing the right thing at the time, but we weren't. We were creating a lot of problems. And if you haven't seen Dope Sick or read The Empire of Pain yet, learn a little bit more about Purdue Pharma and how we got hoodwinked. I will say that when they told me OxyContin was less addictive, I was pretty skeptical, but I wasn't writing scripts. So I recommend that prescribers read that. We license the board licenses MDs, DOs, PAs, podiatrists, and acupuncturists. We don't license nurse practitioners, any advanced practice nurses. They go to the nursing board. We don't license dentists. We don't license chiropractors or naturopaths. But I believe those boards will look pretty strongly to our guidelines. Certainly, we hope so. The board is in process of writing a set of rules incorporating what is in the statement of philosophy into code, into what would be legally binding. We are modeling that, I am modeling that after the rules adopted by the Washington Commission. So if you want to know where it's headed, look up the rules as promulgated by the Washington Commission. I wasn't particularly happy with some of their formatting and the way they did with the document. I tried to simplify it and make it as understandable as I could to doctors, but then the lawyers got involved again. That happens. So I will stop there. One thing I do want to mention is the ECHO program offered at OHSU. I understand it's offered a few times a year. It is generally oversubscribed, but the format, as I understand it, is it a chance once a week, I think, for a period of 8 or 9 weeks, something like that, maybe 13 weeks. I'm not entirely familiar with the details, but it is a chance for a limited number of prescribers, and I want to say it's on the order of a dozen, to get together by teleconference and discuss their problematic patients, try to get advice, try to share what's best. And I would applaud anyone who would enroll in that program. Our hope is to avoid these issues, help prescribers stay out of trouble by providing what is considered state-of-the-art care. It's not that we want to do less work, although we do. We really want the patients to be safest, getting the best possible care. So questions for me before yeah, ECHO program is awesome. That's great. That's certainly what I've heard. Questions? I can't hear you, Ian.
Dr. Ferris, thank you. And I know it's very kind of you to offer to answer a few questions. And so sorry about the slide situation. We had 2 slideshows, one for Dr. Coelho and then a new one. And there was, these are how things go. If you do have an extra minute, if anybody has a question, then please drop it into the chat. And I know, Dr. Ferris, as you mentioned, you have a short turnaround.
I'd rather answer questions here than go to the other meeting, but I'm supposed to be where I am.
Okay, well, that's great. Yeah, does anybody? If anyone has, and I see Carrie's comment about ECHO, that's great. You, Dr. Ferris, you're obviously reading the chats as well. So maybe I'll just turn it over to you for another minute or so. And if anybody has questions about any of those things that Dr. Ferris was just talking about, please. And yes, definitely. Thank you.
Oh, I will say too, I take calls. One of my better parts of my job is actually talking to other clinicians. In the operating room every day, I was talking to dozens of them, and now I sit in front of a really big computer screen. So chat me up. A couple times in the last couple months, I've gotten calls from prescribers quite concerned about what we were going to look at in the PDMP, that they were going to step out of lines. And I had to say, you're not the ones I'm worried about. I mean, if you're calling up and looking for some help, I'm pretty sure you're going to stay out of trouble. The people who are flying solo and thinking they're really the ones who've gotten in the most trouble are people who think they know more than everybody else, and that I think applies across the practice of medicine. There are very, very few licensees. We have 24,000 plus licensees. Very few who get into real trouble. The ones who do, I think if I see any pattern, it's a loss of humility.
You see these, Dr. Ferris?
I do. Investigations per year. Yeah, we get over 800 complaints a year. I'm going to tell you that a major portion of them, probably on the order of 1/3 to 40%, are closed with no formal investigation. We are obligated by law to look at the complaint, but if we get a complaint that the office staff was rude to you, that doesn't fall into the Oregon Medical Practice Act. If we get a complaint about the bill, that doesn't fall into the Medical Practice Act. I'm looking at one today, for instance, who's I shouldn't go into detail. There's just no credibility to the medical aspect of the complaint, but we have to look at it. That will probably be closed without a formal investigation. Another route is, just for your own edification, in this preliminary process before opening a full formal investigation, we might ask for medical records. Your office may get a request to send us the records on Paul Coelho. And I would look at those and say, I see nothing here to implicate negligence. And then we will close it, and you as a licensee will never formally know that you are under investigation, so that you don't have to answer yes the next time you re-credential and the question comes up, have you ever been investigated? If you get a formal investigation, chances are quite strong that it will be closed with no formal action. Just statistically, of the ones that we look at formally, well over 80%, and I want to say closer to 90%, are closed with no formal board action. So you would have to answer yes, you were investigated. Was any action taken? Nope. What are the
People are they're hoping to have your slides, and we will definitely get those to people after the conference for sure.
A minimum MED for prescribing naloxone? No, we don't look at naloxone. Oh, naloxone? Oh, I'm sorry, I was thinking of buprenorphine. No, we don't have a formal rule on that. Dr. Coelho could probably answer that. I think, why not prescribe naloxone? It probably is overpriced, but what isn't? I think, anybody who's on 50, Paul, can speak up to that better than I can. Two shows that you stated may be of interest. I think you may have misunderstood me. There are a list on the board site of topics of interest, and then the statements of philosophy. Not all of them are going to be relevant to all your practices, of course. Yeah, slides.
It was Dope Sick. What was the book, Dr. Ferris?
Oh, the book. The book was, one's a book and one's a show. The show is called Dope Sick. I think it was, I want to say Amazon Prime. I don't remember. They all jumble together, the streaming services. The book, Empire of Pain, I think is more accurate than Dope Sick. Dope Sick is dramatized. Probably a pretty accurate reflection of the overall picture. But my wife who reads very little nonfiction, said, I have to read Empire of Pain. It was absolutely compelling and frightening for all the right reasons.
Any last things, and then we will. I know we'll thank Dr. Ferris, and I'll just turn this over to Dr. Coelho.
And any questions about the actual medical aspects, I will defer to Dr. Coelho. He's one of our consultants. So we have others, but Paul's got it. Thank you all for listening. Again, call me if you have questions or issues, concerns about what the board does. Happy to try to help.
Thank you, David.
Thanks, Paul.
I'm going to turn this over to you, Dr. Coelho, and I'm going to just be here in the background. If you need me, let me know.
Thank you, Ian, and thank everyone who showed up today. A lot of you, I know you're my friends. We've been all doing this for a long time. If it's possible to put the slide deck up now, that would be helpful, and you can advance to the next slide. And for folks in the audience, these slides, it's a combination of mine and David's, and they'll be available to you. I'm not sure in what format, but you could email David and I if you want them. We could send them to you too. I have nothing to disclose. Next slide, please. So I'm going to talk briefly and quickly here through these slides. They're long, but you will get copies of them. So if I don't dwell on a topic, you can go back to the slides, or you can ask me a question. I'll be at this conference today and tomorrow. Feel free to ask questions because I'm going to be moving quickly. Next slide, please. Next slide. So I'm going to briefly show you our 5-year data. There were about 2,000 referrals. 308 of those were high-dose patients, greater than 90 MED. Next slide. And this is the demographics of the high-dose patients. Average age 59, 56% female, 95% non-Hispanic white. That's a reflection of Marion County, where we are, and perhaps a referral bias. We're a referral-only clinic. We don't take self-referrals. We see what's sent to us. Next slide. So this is what we actually did. Of the 308 patients, we tapered 135 to 90 MED or below. 3 are currently tapering, unclear which direction they'll go. 76 patients were unable to taper. We diagnosed iatrogenic opioid use disorder, transitioned them to buprenorphine. 92 refused to taper. They had one visit or a telephone call and said, hey, I don't want I don't want to taper, your clinic's not for us, and they left. We have 2 patients who are on high doses. One's a palliative care patient at 5,000 MED, and the other is a non-palliative care patient at 120 MED. Next slide. So this is a depiction of the dose difference between patients who successfully tapered in blue versus those who were unable to taper, and we transitioned to buprenorphine. You notice that the bias in the buprenorphine patient is much, much higher doses. The average, or median dose, I should say, the average is skewed. The median dose in the buprenorphine transition is about 340 MED, whereas the average dose in the taper group is 187, roughly 50% less. Next slide, please. This is a word about quote unquote forced tapers. You'll hear people throw the term around forced tapers. We consider our tapers to be compulsory. If you're on high doses and you come to us, we'll tell you in advance of the visit that, look, we're going to taper you or transition you to buprenorphine if you can't taper, but we won't keep you at the high dose. Everyone's free to leave, and 92 did. And so those aren't forced tapers. If you choose to stay, you're going to taper or transition to buprenorphine if you have chronic non-cancer pain in our service. Next slide. So this is a look at the 3 quote unquote consensual tapers studies that have been done. 80% of patients dropped out or refused to taper, and there was no firm endpoint to the taper. So when you look at our data on the previous slides, you see when we said we tapered, that means we tapered to below 90. And you can see from the data of the actual quote unquote consensual taper trials, they just don't work. Patients won't do it. Next slide. I saw a question there, MED, and somebody's answered it already. Thank you. So chronic pain does not confer resistance to addiction. This is important to remember. One of the, there were a bunch of old sayings back in the heyday when pain was the 5th vital sign. And one of them is directly from cancer pain management. Pain is whatever the patient says it is and occurs whenever the patient says it does, which is essentially carte blanche to just increase the dose in the presence of tolerance and increase it and increase it. Well, Edlund and Mark Sullivan was a part of this paper, and he'll be speaking later today. Edlund determined that the number needed to harm, that is, the harm being iatrogenic addiction, when a person's dose is held above 120 MED, is about 1 in 17. So 1 in 17 become addicted to their opioid, prescribed opioid. Next slide, please. From our data, that number diminishes to 1 in 3 when the dose is held above 240 MED. 1 in 3 patients become addicted to their opioid, can't taper, and need to be transitioned to buprenorphine. Next slide. Next slide. I'm going to talk about suicide because it's a very hot topic. There's all kinds of anecdotes floating out there that if you taper patients, they'll commit suicide. I believe that if you taper too quickly, and if you don't have a buprenorphine rescue arm. So this slide shows our 5-year suicide data. We had 188 patients with suicidal ideation, no attempts, and 147 patients with suicide attempts. Most of those, 140, were prior to indoctrination into the clinic. We had 7 contemporaneous suicide attempts over the last 5 years. It says, can you make that slide big again? Guys aren't that good. Thank you. 79 of the 147 reported that they had a prior suicide attempt. We asked on our intake questionnaire, that's only 54% reported it when asked. The others were discovered through chart review. Next slide. So as I mentioned, there were 7 contemporaneous suicide attempts over the last 5 years. 140 were historical. Next slide. When you look at the risk factors for suicide, tapering was not one of them. But bipolar disorder was the most powerful predictor. When you look at all 147 patients, odds ratio of suicide with a bipolar patient is almost eight times that with a patient without a suicide attempt. And next was methamphetamine and cocaine history, 3.5% or 3.5-fold increase suicide risk for patients with 5 or more emergency department visits in a year. So folks under distress. Alcohol abuse, 3.22%, 3.22-fold increase. PTSD, opioid use disorder, and you can see at the bottom of the list, tapering actually looks like it was protective because all of the suicide attempts, the vast majority occurred in patients who were on low doses and weren't being tapered. Next slide. So this is the Bravo taper flow sheet. This is basically what a number of us that are presenting today were part of building this. It was headed up by Jim Shames, and this is what we use in our clinic. Next slide. Next slide. Okay, so now I'm going to jump to cases. These are actual cases that we've seen in the clinic. Robert's a 53-year-old gentleman with chronic back and left leg pain. His past medical history is significant for Hep C, PTSD, ADHD, methamphetamine abuse, and tobacco abuse. His fibromyalgia survey questionnaire score is 13, which we consider positive for fibromyalgia. His medications on intake were methadone, 10 milligram tabs a day, and oxycodone, 10 milligrams 6 per day. His total MED was 390. Next slide. So just some general thoughts about tapering. Velocity matters. The rate at which you, or the tempo at which you taper matters. 10% per week is way too fast for a high-dose chronic pain patients. That's perhaps appropriate in an acute setting where the patient's, threatening suicide or has really extraordinary aberrant behavior. But for patients that are tolerant and have been on opioids for years, 10% per week is much too fast. 10% per month is appropriate for patients who are on less than or equal to 300 morphine milliequivalents per day. 10% per month may be too slow when the risk and dose are high, and we'll get to that. Delaying a taper for a month or two is reasonable, particularly with new patients who don't have aberrancy or florid opioid use disorder, and you're trying to gain and build trust. Pausing a taper is permissible during stressful times, the holidays, weddings, deaths in the family, etc. However, once you start the taper for high-dose opioid patients, you should never go backwards. Pause, but don't take them back up to high doses. Sometimes, not always, the litmus test for opioid use disorder is the inability to taper slowly. Next slide. So there's just some rules of thumb that we've applied in our clinic. If the dose is 120 MED and below, about a 3-month taper is slow enough to be humane. For 120 to 250 MED, 3 to 6 months taper, 250 to 500, 6 to 9 month taper, and 500 MED to 1,000, 12-month plus. Next slide. Okay, this slide shows taper velocity. When we started our clinic, some before the CDC guidelines came out, so early 2016. Julie and I, my colleague, we've worked together for a decade tapering patients and transitioning to buprenorphine, and we had come to a 20 MED per month taper rate is what we found worked, just empirically. And you'll see I've plotted in the lower left-hand corner of this slide 20 MED versus 10% per month. And you can see the two overlap. So we kind of came into agreement with CDC guidelines by happenstance, by our actual experience. Things get different, however, when the dose is very high, 1,000, above 300 MED, then tapers can become really prolonged. Next slide, there we go. So, you have to ask yourself, when a patient is on 3,000 MED, should I taper them over 5 years or 4 years? Or should I be thinking about transitioning to buprenorphine? And, the idea is you should be thinking about transitioning that patient to buprenorphine because, a 5-year taper is a death by 1,000 cuts. It's just, patients are miserable. And my suggestion would be get your X waiver and be prepared to use it if you're seeing these ultra high dose patients like Julie and I see. Next slide. So other strategies, part of Bravo is other strategies, recommending other strategies to patients. But the fact of the matter is patients who've been on high dose opioids for years got there because it's the final common pathway. In other words, they've tried everything else. So there's not going to be a home run. Oh, did you think of acupuncture? It's just, I'm sorry. Most high-dose long-term opioid therapy patients have tried everything. Many high-dose long-term opioid patients have comorbid depression, anxiety, PTSD, bipolar, and those things worsen in a taper. Take that seriously. If you have supportive therapy, even if by yourself or a medical assistant, use it. It can help placate the symptoms of withdrawal and distress. Don't buy into the narrative that you've got to replace the opioid that you're tapering or weaning with something that quote unquote works. Next slide. So withdrawal terrifies patients. All chronic, high dose chronic pain patients have had withdrawal at one time or another, even if they tell you they haven't. And it's terrifying that, just the thought of it terrifies them. And so you need to be aware of that and be prepared for that. They're not going to tell you, oh God, I'm afraid of this withdrawal. Some will, but they are afraid of withdrawal. Next slide. Next slide, please. And this is just, confirmation of that from the written literature. Next slide. It's fear of withdrawal that perpetuates use. So what is it that terrifies patients? Well, these are the early symptoms of early symptoms of withdrawal include muscle aches, restlessness, restless leg syndrome. Restless legs is kicking the habit, anxiety, lacrimation, runny nose, sweating, inability to sleep, yawning very often. Later symptoms, diarrhea, abdominal cramping, goosebumps, nausea, vomiting, dilated pupils. Next slide. So the way I monitor withdrawal symptoms, and we monitor in our clinic, is the COWS, Clinical Opioid Withdrawal Scale. You can't use pain or like a PEG scale or a VAS, numeric rating scale. That doesn't capture the distress of withdrawal. So if you have high dose taper patients that you're seeing, my advice would be look for symptoms of withdrawal in that clinic explicitly. Bring the cows in with you if you don't know it and look for it. Next slide. This is just the time course of withdrawal from various medications. And I want to mention something here since fentanyl is there. You all know that illicit fentanyl is in the state. In the last year, we've had 9 patients purchase illicit fentanyl on the street, and we found it from urine drug screens. In the prior 5 years, there were 0 cases of fentanyl. Meth was in everything. The reason fentanyl is becoming popular, this is supply driven, is because withdrawal is so short. It occurs in about 6 hours. So you have people that are hoping to buy cocaine or methamphetamine, and it's being cut with fentanyl. And the reason it's being cut with fentanyl is because meth can last 3 days. So you don't need to buy it again for 3 days. If it's cut with fentanyl and you become addicted to the fentanyl, you've got to get another fix every 6 hours. That's what's driving the fentanyl in the state. Next slide.
Ready to connect.
Sorry, you're hearing my speaker. This is the COW scale, and I've got a link to where you can download it if you don't have it. Next slide. Taper rules of thumb. We offer tapers for everyone over 90 MED. I know that's somewhat arbitrary, but that's what we picked in our clinic. And we negotiate the tempo to some degree. We don't start a taper until the second visit if the patient's stable, long-term opioid, a legacy patient, trying to build trust. If the patient's co-prescribed benzodiazepines, we'll leave those alone and taper the opioid first. We're picking our battles. Once tapers are started, we don't go back, but we do offer pauses. And then we see taper patients frequently, a minimum of every 8 weeks, if not sooner. Next slide. So initially, Robert was very hesitant to taper, but no one else would see him. We co-prescribed nasal naloxone and tapered him by 10 milligrams of methadone per month over 9 months to 90 MED, and then referred him back to his primary care provider. Next slide. Jane, and by the way, again, these are all real cases, and you'll notice the fibromyalgia survey questionnaire score on all of them. They're all positive for fibromyalgia. I should mention fibromyalgia usually begins in adolescence. It becomes measurable or diagnosable in adolescence. It tends to persist throughout life. So all of these patients were probably started on their opioid for fibromyalgia, unbeknownst to the prescriber. So Jane's a 37-year-old woman with lupus and fibromyalgia. Her FSQ score is 13. She's referred from the same PCP as the prior patient. Her past medical history, unbeknownst to the PCP who referred her, was significant for opioid use disorder. She was quote unquote detoxed, which I don't recommend, in Portland 3 years ago. And she was sent with 72 30 milligram immediate release oxycodone per day. I'm going to repeat that because when I read her PDMP file, I couldn't believe it. I called the primary. I said, she's on 72 immediate release oxycodone per day. And he said, yeah. And he was unapologetic about it. You know, the MED was 3,200. Next slide. So here are some rules of thumb when you're going to do a buprenorphine transition. You can treat buprenorphine as if it has a morphine equivalence of 240, 8 milligram, that is the typical 8 milligram sublingual tab. And this is what Julie and I have used for the last decade, is when patients are on high doses, we do this transition. So this young woman was on 3,200 milligrams. My goal with her was I was going to taper her to 1,000 or below and then transition her to buprenorphine 8 to 32 milligrams per day. This is empiric. This is stuff that you learn from doing it. Next slide. Planning buprenorphine transition. So when you've got a high dose legacy patient, you've got time to plan. You know, you don't need to freak out when you see the 3,200 on the PDMP run, because she's been on it for years. She has a high tolerance. So, you know, calm yourself, take a step back. You know, when you are going to break the news, broach the subject that there's going to be a taper, bring a calendar into the room if you're going to do a transition to buprenorphine, and put the dates down, write them down on the calendar so that the patient understands the process, because they are terrified. They forget everything you say in the room that day. Bring the calendar in, write it down, give it to them. We load a patient with gabapentin if they're not already on it. When we're planning to do a transition to buprenorphine, we get them up to 300 milligrams TID if it's not already on board. So it's a good idea to plan the transition to buprenorphine a month in advance so that you can load the gabapentin and the patient has an opportunity to gird their loins, so to speak. On withdrawal days, you know that for transition to buprenorphine, for induction, patient has to be in withdrawal. I'm not going to go into microdosing. Patient has to be in withdrawal for 24 to 48 hours, depending upon the drug that they're taking. During withdrawal days, we will prescribe tizanidine 2 milligrams TID. It helps with withdrawal. We use 24 hours for withdrawal for most opioids, oxycodone, morphine, hydrocodone, heroin, but 48 hours for fentanyl and methadone. And the idea behind the withdrawal period is to avoid precipitated withdrawal, POW. Buprenorphine has a very high avidity for the receptor, for the mu receptor. And so if you put it on board, it's like a shot of Narcan. Patients don't like it. I've done it a few times. They go to the emergency department. It's not life-threatening, but it's very dysphoric producing, and patients are not going to forget it if you do that to them. So it's important. It's an opportunity for them to, when you're going to plan the induction, have them bring their largesse of medicines that they've accumulated over the years, opioids, to that visit when you're calendaring the induction date, so that you can dump them if you've got a dump site on site like we do at Salem Health. There's an old wives' tale that you have to taper patients to below 30 MED to do an induction with buprenorphine. That's from SAMHSA, the old SAMHSA tip 40. That's not correct. You don't have to taper patients. I had a 1,000 milligram patient several years ago probably 10 years ago, who I wanted to refer to a prominent hospital in Portland for induction. And they said, well, taper her to 30 MED before you send her. So I had to learn how to do this myself. Next slide. So this is just a picture of a calendar that we bring into the room and give to the patient when you're going to plan an induction. You've got a high dose patient that you feel is lapsed into opioid use disorder. Bring the calendar in the room. You know, I've put on here today's visit, withdrawal day, induction day. Write it down for them so that they don't forget, because again, they are terrified. If you have a medical assistant or someone in your clinic who can, you know, be the shoulder to cry on through this process, assign that, pick a person who's good at that. We have an MA in our clinic who became expert at it, and she'll walk people off the ledge during withdrawal and tapers and such. Next slide. So this is Jane's taper. It was supposed to be 12 weeks. That's what we agreed upon. But of course, with her history, she couldn't taper and she overtook her medications. We tapered her to about 1,900 MED and then did the induction at week 10 with 8-2 buprenorphine BID. She did great. Next slide. This is some withdrawal attenuation medications. Again, this presentation will be available. You can use these if you want to. Next slide. Jason, this is the third patient. This is a 39-year-old gentleman with chronic widespread pain, anxiety, depression, and PTSD. His fibromyalgia score is 20, again, positive, and I'm not making these up. These are actual patients. His pain catastasizing score is 23. His past medical history is significant for a gastric bypass. He was referred by the same PCP as the prior two patients. This is real. He was prescribed oxycodone immediate release, 15 milligrams, 6 tablets a day. His MED was 135, as well as diazepam and soma. Next slide. Jason was very reluctant to taper. Almost all of the patients are reluctant to taper. That's why consensual taper trials don't work, because patients, if given the option, aren't going to want to taper. We tapered to 112 MED over 3 months, but he began overtaking because he couldn't taper, and he basically self-diagnosed with opioid use disorder, and we transitioned him to buprenorphine. And he did great on buprenorphine. I referred him back to the PCP. This particular PCP was referring so many dangerous patients that we negotiated with him to get his X waiver to take over his patients when I did the transition and stabilize them and send them back. So we sent him back to the PCP. He subsequently got lost to follow-up from that PCP. And 2 years post-taper and buprenorphine induction, he attempted suicide by an overdose on cyclobenzaprine. This is the one contemporaneous high-dose patient that attempted suicide over the 5-year period. The circumstances, as you see, are a little extenuating. It was 2 years post-taper, but he was taken off of his buprenorphine for reasons that aren't clear to me because I was no longer seeing the patient. Next slide. Mona. Mona's a 57-year-old disabled retired woman with chronic widespread pain, fibromyalgia survey questionnaire score of 13, pain catastasizing of 15. She's prescribed methadone, 90 milligrams a day, and oxycodone 5 milligrams TID for a total morphine equivalent dose of 295. Next slide. Mona and her attentive spouse, he was at every visit and very vocal, reluctantly agreed to a taper below 90. I prescribed nasal naloxone and tapered her to 60 MED over 8 months. Her taper was horrible the whole time. With every visit, I'd ask, do you want to transition to buprenorphine? I'd recommend you transition. No, I don't want to taper. And then at the last visit, she yelled at me, I'm not an addict. Buprenorphine wasn't on the table. So, you know, this looks like a successful taper. She made it to 60 MED, I think, over a year or so. But some 18 months post-taper, she found someone in Portland who would take her back up to the high doses. and she's stayed with that provider, a nurse practitioner in Portland since. She and her spouse told me that she reported me to the Oregon Medical Board, made a formal report against me. I never heard it because, as David says, if they do a review and they close the case, they close the case. So Mona's taper was not successful, but she couldn't transition to buprenorphine. She couldn't bridge the gap, cross the Rubicon to buprenorphine. It was insulting to her. Next slide. So some closing thoughts. Adverse risk selection. Mark may talk about this later when he's speaking. He explains a lot of the suffering and despair associated with high impact chronic pain. Virtually all of the patients with high impact chronic pain have histories of trauma, comorbid mental illness, and addiction. Adverse risk selection also explains why chronic pain in and of itself is a risk factor for addiction. I and Julie, my partner in our practice, we have a low threshold for the diagnosis of iatrogenic opioid use disorder when a patient's dose is above 240 MED and they're struggling with the taper. In my opinion, the missing link in published high-dose taper trials is a buprenorphine rescue arm for those that have lapsed into opioid use disorder. Suicide is not a fait accompli with a slow, thoughtful taper and liberal transitions to buprenorphine. As I said, we had only one case amongst the 211 patients that we tapered or transitioned. Next slide. Okay, there are references at the end for those that are interested, and that was fast, but I think we have a little time for questions if there are questions.
I just want to say on behalf of everyone, thank you, Dr. Coelho. That was, as somebody who doesn't know much about this, honestly fascinating. And please drop questions into the comments right now. I'm going to let you have the stage, Dr. Coelho, but I'll help if needed. But it looks like you're doing a great job without my help. So please, if anybody has comments or questions, or I'll ask a silly question that may be really obvious to everyone. You mentioned an X waiver. Is that, does everybody who know how to, is that something that's easy for people to figure out and do? Or is that something people need to know how to do?
So the X waiver to prescribe buprenorphine sublingual for addiction, you need to apply for an X waiver. You no longer need to do the 8-hour class, although I would recommend that you do. And so those of you, if you're going to see high dose patients, I would recommend you get the X waiver and make that available to your patients. I really think that our lack of suicides was because of liberal use of buprenorphine. There's a lot of controversy around tapering now. New CDC guidelines are coming out, and there's a lot of anecdote around about transition to illicits or suicide with taper. And again, I think that's because of the lack of recognition of iatrogenic opioid use disorder, prescribed opioid use disorder, and not offering patients a transition. There was a very high-profile case in the news recently about a patient who sustained a spinal cord injury and all of the sequelae of the spinal cord injury, osteomyelitis and such. And there was a bad handoff, if you will, from the written reports that he went from surgical care to a pain clinic, and there was an immediate drop in his morphine equivalent dose from 500 to 250. And he subsequently commits suicide. Well, that's a 50% drop instantly. That's insane, So, and there were clear signs from the written report that he was overtaking his medicine. He was running out early. He'd lapsed into opioid use disorder. No harm, no foul. Offer that fellow a transition if he'll take it to buprenorphine. So, when you're tapering, taper slow, 10% per month. And those who can't taper can't taper because they've lapsed into addiction, whether or not they realize it, and you should offer them buprenorphine.
Question. Laurel has a question about implementing. Is it Sublocade?
Yeah. So Most of my patients are Medicare and Medicaid, and Sublocade's about $1,000 a month. Not on the table. I mean, it's fine. I had one patient with Sublocade, and he comes in for his monthly injection. But I think that's very costly for healthcare systems when sublingual forms work every bit as well. What's the approach to a patient with chronic stable pain on doses less than 90 MED? I'd leave them alone personally. Low dose opioids. Let's not extend the mandate to no opioids. You had started to not go back up during a taper. I'm not sure what Billy means there.
I think Billy's saying you said earlier not to go back up after you start the taper, and I think just looking for a little bit of further clarification.
Sure.
I mean, yeah, sure.
It's easy to lose ground quickly by going back to where you started. So don't. Here's my advice, and this comes from being in the trenches. If you're willing to see high dose patients, and your rule is that it's going to be a compulsory taper or transition to buprenorphine, like in our clinic, because we don't think that there's any utility to high dose opioids. Let them know on a telephone call before they come, so that's not an ambush to them. Put the menu in the window. Let them read the menu. If they don't want the menu, they don't have to come. And if they come, they can leave. These aren't forced tapers. But if your philosophy is that you don't feel that these high doses are more benefit than risk, then let the patients know in advance. So early on, when I started doing this, they'd hear that from me on their first visit, and they're like, "Oh my God, no! I don't want to be here." So now we've moved it so that Julie and I will look at the PDMP. We know if they're on high doses, and the MAs will call, or MOAs will call and say, "Hey, in our clinic, we're going to offer you a taper or transition to buprenorphine. If you know that and you want to come, then we're happy to see you. But if you don't want to come, we understand it. Here's a list of other pain clinics." Also, what we do is, because we look at the PDP, by the way, we do everything in advance. We're no longer ambushed. We don't walk in and find out somebody's on 3,000 MED. We know it well in advance. We pre-charted on this patient. We looked at the PDP, Emergency Department Information Exchange, their previous records. We do our homework. We also know if they're seeing multiple prescribers for pain medicines. This is important, okay? In 2013, only 0.5% of Oregonians saw 4 or more people for opioids in a year. 0.5%. Now that's less than 0.3%. So when you review the PDP, hopefully you're all doing that, and you see multiple opioid prescribers, 4 or more, you're seeing a unicorn. That's an opportunity for a difficult conversation. That's more than 3 sigma. That's somebody who's a way outlier on opioid prescribing. And it's a strong indicator of drug-seeking behavior. So let them know in advance, "Hey, Mr. Jones, your PDMP file is flagged. And if I see you, my PDMP file will be flagged because you're seeing multiple prescribers for pain medicine. This is dangerous. You're at a high risk for an unintentional overdose, and we want you to know that in advance." Okay, off the soapbox. More questions?
Yes, there was a question about the MED for methadone, and if there's a difference between liquid or tablet formats.
Methadone is 30 to 1 morphine. So, 1 milligram of methadone is equal to 30 milligrams of morphine. I put a link in the slideshow to the Oregon dosage converter. It was put together by Roger Chow a few years ago. That's the one we use. So if somebody's on 90 milligrams of methadone a day, that's equivalent to 270 milligrams of morphine. So those calculators are easy to use, and they're on the web, and they're free.
You see Carrie's question, Dr. Coelho. She's wondering about that last case that you presented.
Good question, Carrie. I mean, that wasn't a success. It's embarrassing to me, and I'm being honest with you. It looks like a success. You look at my data, about 68% of patients taper to transition to buprenorphine. That's unheard of in America. But it hides cases like that, and that's why I bring it up to you. Do you think that this person would, for all intents and purposes, would have been better under a palliative care approach, even though this isn't cancer pain, should just kept her there? There's one that I decided to do that, and I talked to David about it. I called him. She's on 5,000 milligrams of morphine a day via an IV. And she's a young patient that never should have been started on opioids. The dose was so high, I don't feel I could safely transition her to buprenorphine, or she could be transitioned to methadone, not from me. That'd be a violation of the Harrison Act. But I kept her after discussion with the board at that enormous dose because no one else will see her. This patient, the dose is much lower, and it was really, with many patients, particularly older patients my age, it's like, I'm not an addict. Buprenorphine, no. In spite of my experience, success with buprenorphine transitions, the 76 patients we transitioned, their visual analog scale dropped on average by 1 point, whereas the 135 patients we tapered, it increased by 1 point. Neither one of those are clinically significant, but it's interesting. I think she would have done great, just like everyone else who transitioned to buprenorphine. And, when you look at these folks, most of them have been on disability for years. They've given up life roles. And so when you do the risk-benefit assessment in your mind, there's really no benefit that you see. What is this opioid permitting? These are folks who haven't worked for a decade or more and have checked out of a lot of life roles. But your question is a good one.
We have just about a minute left, Dr. Coelho, because we've promised people we're going to stay on time. But I do want to just remind everyone of what Dr. Coelho mentioned earlier, which is that he's going to be here both today and tomorrow. And Dr. Coelho, I don't want to put you on the spot because I hear you saying that one of the keys is to not put people on the spot for success, that you let them know in advance. And I'm going to, unfortunately, put you on the spot. But I wonder if you might do some of the networking opportunities that come up a little bit later today. And just a reminder to people that is a chance to actually see and be seen one-on-one with another person for just a few minutes. So if maybe Dr. Coelho will do that. And if I put you on the spot, you can tell me I'm not doing this right. So I'm going to just say thank you. And if anybody, wants to, give a shout out and then, yeah, Dr. Coelho, of course, obviously with your expertise, please, you can ask questions and add comments, I'm sure, along the way as we go. Any final things before I introduce our next speaker?
Happy to be here. Thank you, guys. Looking forward to a good conference.